Good evening and welcome to the fifth presentation of basic modules in infectious disease. I'm Dr. Alia Salim, clinical pharmacist, ID forum member and of Federation of Clinical Pharmacists in India. Before we begin, I would like to go through a couple of points. Participants can post your questions in the comment box below the video thumbnails in the website, or you can post your questions at the email fcpaofficial@gmail.com. And then a feedback form will be made available towards the end of the session, and participants will get your certificates after you complete the feedback form. In any queries, you can mail it at fcpaofficial@gmail.com. So without any further delay, I would like to welcome our host, Dr. Grace Mary John, BCITP, ID forum member of Federation of Clinical Pharmacists of India. Today's topic is clinical microbiology, atypicals, and anaerobes. Over to you, ma'am.
Thank you very much, Alia, for your kind introduction. So without further ado, I'll also try to start. So far, we've been talking about the basic microbiology, and we've been having, we had 4 sessions so far, and that included our major ones, the gram-positives, the gram-negatives, and we saw in detail, the things that we commonly see, the things that we commonly get cultures, all the E. coli, Klebsiella, or Streptococcus, Enterococcus, Staphylococcus, and all that. Now we are coming to, the mop-up of microbiology, the ones that you usually don't see on your culture reports, but are very important also to keep in your mind that can cause infection. So today I'll be talking about the anaerobic bacteria and the atypical bacteria. So I do not have any disclosures for this presentation. And the objectives, like I said, is to know about the basic microbiology of these 2 kinds of bacteria in this session. Now, coming to anaerobes, I'm sure that all of you know what anaerobic organisms are. Aerobe is something that requires oxygen, and anaerobe is something that need not, have oxygen for their growth. So anaerobic bacteria, like you can see, they are unable to grow in a physiological concentration of oxygen. And these organisms are usually our commensals. That means they are inhibiting our body, whether it is our skin, whether it's our oral cavity, whether it's our gut, whether it's our genitourinary tract. A lot of bacteria that are, that doesn't require so much oxygen lives within us. And it's also seen outside of the human body as well. Now, how do you classify anaerobic bacteria? Anaerobic bacteria can be classified based on their requirement for oxygen. That means there are obligate anaerobes. That means they cannot tolerate oxygen. Okay, if there is oxygen, they'll die. So best example is the Clostridia, the Clostridium difficile, and the Clostridium tetani. All these ones, they cannot afford to be in an environment that is rich in oxygen. Therefore, these are called as the obligate anaerobes. And then there is an aerotolerant anaerobe. These are also called as the moderate anaerobes. They do not use oxygen to live, but they can exist for a certain period of time, but not for a very long period of time. And then comes the facultative anaerobes. Facultative anaerobes, even in our gram-negative, gram-positive earlier discussions also, we had seen the common ones that we see. That means even if there is oxygen, they can live. And even without oxygen, they can live. So how do they do that? Using fermentation. Okay, so in an oxygenic environment, they will thrive. But even without oxygen also, they can thrive. These are called the facultative anaerobes. Now, coming to the major classification as to how you classify these anaerobes based on the morphology and the structure. So broadly divided into spore-forming and non-spore-forming anaerobic bacteria. Now, coming to the spore-forming bacteria, again, based on the gram staining, you have gram-positive and gram-negative. Now, the spore-forming are usually the gram-positives and these are the rods, that is the bacilli. Okay, so gram-positive bacilli, which are the Clostridium, comes under the spore-forming anaerobic bacteria. And then under the non-spore-forming bacteria, we have classifications with regard to the gram staining. We have both gram-negative and gram-positive. And gram-negative are usual rods, and those include our Fusobacterium, Bacteroides, and Prevotella. Okay, and in the gram-negative and the gram-positive, it's further divided into the shape, cocci, and bacilli. So in cocci, it is the Peptococcus and the Peptostreptococcus, which are usually in the oral cavity. And in the bacilli, you have Actinomyces, Lactobacillus, Propionibacterium, and Eubacterium. Okay, so what I have shown in this slide are the usual ones that we are concerned about. Okay, now going in further detail to the anaerobes of clinical importance, like I had mentioned before, the infections caused by these anaerobic organisms, they are, from head to toe, it can cause, and mostly they are associated with abscess formation, and mostly they are polymicrobial. And the easiest way of defining them, or easiest way of categorizing them, commonly during practice, one thing that we look for is, where is the infection? Is it above the diaphragm or is it below the diaphragm? Okay, so above the diaphragm, the oropharyngeal cavity, you have Actinomyces, Bacteroides, Prevotella, Fusobacterium, Corynebacterium, Peptostreptococcus. But when it comes to below the diaphragm, your GI, you have Clostridium, you have Lactobacillus. Okay, so based on this, our therapy might change, because one major way to see it is below diaphragm, metronidazole, above diaphragm, clindamycin. Is something that has been commonly being taught. So that's easy to just keep in your mind, but you'll also have to keep in mind the resistant patterns also, so that you can come up with the best possible drug. So as you can see in this picture, it can cause from brain abscess to periodontal infection to endocarditis to abscesses, various abscesses, whether it's lung, whether it's liver, and the abdominal infections, any post-surgical infections, any polymicrobial infections like an infected wound, necrotizing fasciitis, necrotizing cellulitis, vascular or gas gangrene. So a lot of spectrum of infections that these bugs can actually cause. Now, there are certain things that that easily are being called as the characteristics of an anaerobic infection. So usually it occurs, infections that are adjacent to the mucosal surface, because that's where the flora is. So wherever there is a small breakage in the mucosa, that's when these organisms tend to cause an infection. Now, the predisposing factor, the first one I have mentioned here is ischemia. Now that makes sense, right? Ischemia means oxygen is not there, blood flow is not there. So when oxygen is not there, they tend to grow, okay? So ischemia, tumor, penetrating trauma, especially like for Clostridium and all that, which can cause necrotizing fasciitis or gas gangrene. Clostridium, if the spores of the Clostridium gets contaminated with the penetrating trauma, that can cause a sudden chain of reactions that that are usually to some extent fatal, and therefore having a penetrating trauma, you are at risk for an anaerobic infection. Therefore, you have to cover your infections accordingly. Okay, and any case, whenever you have a GI perforation, always you are at risk of an anaerobic infection. Like I had said, spreading gangrene, immediately spreading gangrene is one of the common things that you have to have in your differential diagnosis to include an anaerobic picture. Now, these infections, they are usually abscess forming, and the pus that is created because of this organism are usually foul smelling and putrid. So any oropharyngeal cavity infections that you have, whenever you drain it, it's usually very foul smelling. Okay, mostly because it is caused by the anaerobes. And it can cause thrombophlebitis, it can cause toxemia. And if you don't cover your patient adequately enough empirically when it comes to the initial management, there might be failure, there will be failure to respond to the treatment that is given. And the one easiest thing is that, you see organisms on gram stain, but it doesn't grow in a routine aerobic culture. Okay, so you have things on the gram stain, but it doesn't grow in the culture. That's the reason why you always have to do a gram stain when you have something for culture, especially because these organisms, like I said, they are always pus producing. So whenever you are having pus, get the gram stain as well, not just the culture, because these might not grow in your culture. That doesn't mean it is not infected. Now, the pathophysiology, like I said, usually they share the mucosal, they are living near the mucosal barrier. And whenever there is a breeze in this barrier, that's when they cause the infection. And they have a lot of virulence factor, a lot of toxins. Some have toxins, some have other virulence factors that helps them with the spreading of the infection and the severity of the infection. Now, up to 5% of the bacteremia that you see are usually anaerobic bacteremia. But the problem is that the cultures, how many of us actually do the anaerobic culture in the right way? So maybe that is one reason why the yield is low. But the problem is that the mortality that can be because of an anaerobic bacteremia can be as high as 45%. Okay, and Bacillus fragilis is the most common organism that is isolated from a blood culture and which is followed by the Clostridium, not the Clostridium difficile, but the other two, the Clostridium septicum and the Clostridium perfringens. Okay, and most of whenever you have something in blood, there always has to be a source, and most of these bacteria are caused 70% of the times because of the abdominal source, 20% of the time it can be from a genitourinary tract, and 5 to 20% it can be a soft tissue infection, like the penetrating trauma that I was talking to you about. Okay, and these can cause sepsis. Now, how do you culture and what are the susceptibility testing for these organisms? Like I said, they are difficult to isolate because of their fastidious nature. It's difficult for them to grow. It takes time for them to grow under the, low oxygen requirement. Therefore, unless you have the right isolation techniques, the right way in which you transport whatever you've collected, and the right way of collecting the specimen itself, unless all these things are in the right place, you will not have this bacteria growing. Okay, and one other thing is that most of the bacteria that we are having now are beta-lactamase producing. Okay, that means it can break down beta-lactam antibiotics. Now, I'll come to that in a short while. And most of these infections as a whole, I'm talking anaerobic infections as a whole, most of these infections can be treated with antibiotic, but usually if there is an abscess involved, surgical debridement, surgical management is the first step, and antibiotics is only secondary. Okay, giving antibiotics is only secondary to surgical management when it comes to, because we need source control. So whenever you have a source, you drain the source and you take off all that thing, and with the antibiotics, you'll be able to mop up whatever is there, whatever is left. Now to a question, infection caused by bacteroid species can be treated with all of the following except A, ampicillin sulbactam, B, clindamycin, C, metronidazole, D, penicillin, E, cefoxitin. I'll give 30 seconds for people to have it in the chat box. This is a very simple question. This is a very straightforward question. I'm having the chat with me, but I'm not seeing anyone answering. Any guesses? It's very easy. Okay, so the correct answer to this question is penicillin. Now, coming back to the slide that I've told you about, most of these anaerobic organisms, they are capable of producing beta-lactamase enzyme. That means they can break down beta-lactam antibiotic. Therefore, that's why that is the reason why most of the antibiotics of choice that are there to treat anaerobic infections include a beta-lactamase inhibitor. Okay, so ampicillin sulbactam is a beta-lactamase inhibitor. Clindamycin and metronidazole are one of the commonest antibiotics that you use for when it comes to an anaerobic infection. Penicillin you cannot because of the beta-lactam, it will be rendered useless. And the cefamycins. Okay, cefamycins are cefotetan and cefoxitin. Okay, so these are the second generation cephalosporin, and these are the other drugs that you can use for anaerobic infection. Now, this is something that we use here. So in the spectrum, I know this is a busy slide and I've highlighted with the green box there. So above the diaphragm, you have a lot of choices, but below the diaphragm, because of the Clostridium and because of the bacteroids, you have a lesser number of antibiotics that you can actually give for serious infection, because serious infections are usually associated with intra-abdominal infections. Okay. Now, the problem that we are facing, like for all our, carbapenem resistance, for our ESBL, similar things we have for antimicrobial resistance when it comes to these drugs, these bugs as well. Because, like I said, we only have a handful of drugs to treat these organisms, and the resistance is actually increasing, especially to the cefamycins, to clindamycin, to the fluoroquinolones. You can't actually use a lot of that. Okay. Now, I'll just touch upon a few bacteria that I thought would be beneficial for your clinical practice. So the first one I thought of talking to you about is bacteroids. So bacteroids, like I said, it's present almost everywhere. It's intestinal, it's oral, it's there in the GU tract. And it is the most aerotolerant. That means it can survive in an oxygenated environment for a short period of time. So the common the common infections that these can actually cause, the first and the foremost I would like to stress upon is the intra-abdominal infections, all the abscesses that these bugs can cause. Then, like the figure that I showed you, because it is there in the oral cavity, it's in the intestine, and it's in the GU tract. All these places, it can cause abscesses. It can cause other infections as well. Now, the susceptibilities of bacteroids, actually, it can vary by species. And I've mentioned the species in the previous slide, like you can see, but fragilis is our most common one. And most are resistant to penicillins, ampicillin, and cephalosporin. That's why, again, I'm stressing the point, the need for you to use a beta-lactamase inhibitor in these cases. Okay, and the cefotetan and cefoxitin resistance are also increasing. Clindamycin resistance, in the Western world, it is nearly 60%. And in the fluoroquinolones, the major fluoroquinolones that we are having, ciprofloxacin, levofloxacin, moxifloxacin. Moxi is supposed to be the best anaerobic cover, fluoroquinolone, but even to moxifloxacin, the amount of susceptibility is actually being reduced. The good thing is that it is very good. It responds very well when you give a beta-lactamase inhibitor. So, which are the beta-lactamase inhibitor that you can try for these organisms? So it includes starting from your ampicillin sulbactam. See, this is something, again, I would like to talk to you about, because usually you see piptas or carbapenems being given. Even amoxicillin clavulinate and ampicillin sulbactam are actually good drugs of choice when it comes to anaerobic infection. And the only thing is, when it's a bacteroid infection, because the resistant rates are higher, if a patient is septic, if the patient is very sick, you try to give a good beta-lactam inhibitor, because as I told you, all these anaerobic infections are usually polymicrobial. So if you have an ESBL kind of an organism and you want to treat it, obviously your ampicillin, amoxicillin, beta-lactamase inhibitor combination will not work. You'll have to go for something higher like piperacillin, tazobactam, or carbapenem. Okay. And now Prevotella and Porphyromonas species, a lot of them, right? Like I said, a lot of them in your mouth, in your, it's there throughout your body. And the Prevotella can cause pigmented and these are pigmented and non-pigmented gram-negative rods, and they're generally resistant to penicillins and penicillins because of the beta-lactamase production. And like I said, if you look at almost all the anaerobes, the treatment is going to be almost the same, except for a very few, which I'll come to. And similarly for the Porphyromonas also, very similar to Prevotella, and the antibiotic choices are also the same. Now, when it comes to the anaerobic gram-positive cocci, which is, the Peptococcus. So these are the gram-positive ones, okay? The others all are gram-negative, except for Clostridium, which is gram-positive bacilli. Okay, and again, the agents that you use are as low as ampicillin can be used. And even in this one, you can see that penicillin even are susceptible to most of these organisms. And mostly they are associated with the oral cavity infections. Now, coming to Clostridial infections, like I told you, these are gram-positive bacilli. These are gram-positive bacilli. The gram-positive cocci are our Streptococcus, Staphylococcus, and Enterococcus. Okay, so this is gram-positive rods, bacilli, and they have extremely powerful toxins and they have extremely powerful enzymes. And if there is a Clostridium infection, it's very crucial that you identify it at the earliest. Otherwise, it could result to be a fatal infection. Now, there are 4 major Clostridium infections that we need to look into, the 4 major species that we need to look into. The first one is a Clostridius perfringens. So this is the one that causes gas gangrene. Okay, it is rapidly spreading. It causes myonecrosis. That means the necrosis of the muscle. And usually because of a penetrating trauma or a crushed wound, which is contaminated by the pathogen. Now, like I said before during our classification, Clostridium causes, they are capable of producing spores. Okay, so if spores are there, then the amount of the transmission also can be much higher. Okay, and that's why it is very rapidly spreading. Then there is our most famous tetanus, okay, which is again Clostridium tetani. And you know what happens when you get tetanus. The reason why whenever your hand or any part of your body get bruised with something metallic, something unhygienic, you tend to get a TT shot, a tetanus toxoid shot, because of the spores. And these there is a very potent neurotoxin called as the tetanospasmin, which causes lockjaw. Okay, and you won't be able to have severe facial spasm, you'll have skeletal muscle spasm, and your body tend to be out of control if you get this infection. That's why it is very important why whenever we have a trauma, that TT injection, if it's not taken within the 10 years time period, the vaccine, you have to take it. The other notorious one is the Clostridium botulinum. Clostridium botulinum is most commonly associated with food poisoning, okay, and it is a neurotoxin. Again, like the tetani, it is again a neurotoxin, and it causes flaccid paralysis. And there are 3 clinical forms: the small food poisoning, the wound infection, and infant botulism. And being in a healthcare setup, to me, the most notorious one is Clostridium difficile, and it is usually and exclusively because of the overuse of antibiotics, overuse of broad spectrum antibiotics. So what happens is that, like I said, your gut has a lot of bacteria, and in the previous lectures, I might have mentioned that your gut has a lot more number of bacteria than the whole cells in your body. Okay, the whole number of cells in your body, and when you give very strong antibiotics, you wash away the gram positive, you wash away the usual gram negatives, and all there is left to grow is your fungi and your anaerobes. Okay, the ones that the antibiotic doesn't cover. So that is the reason why these tends to grow. Okay, and these tends to grow, and these tends to produce spores and causes severe infection in hospitalized patients. So Clostridium difficile, whenever you'll see that a broad spectrum antibiotic was used for that patient. Now, this is a picture of gas gangrene. You can see the black colored bullae. You can see how bad that infection is. So, like I said, the Clostridium perfringens causes this one. And the first thing that you have to do is the early surgical debridement. Whenever you have bullae is like the bubble-like, appearances that with fluid-filled bubbles that forms during a cellulitis or a necrotizing fasciitis. That itself is a very poor prognosis that the infection is out of control. So you need to have surgical debridement to ensure that it is not fastly spreading. And once you have the surgical debridement, along with that, you give antibiotics for a good period for them to act, so that the toxins are inhibited, so that the bacteria is not, as active as we don't want active bacteria. The other one, Clostridium tetani, like I said, for the prevention, it is the toxoid, tetanus toxoid. But as treatment, as for immunization, you have the human tetanus immunoglobulin. Okay. The problem is that if you have already contracted the disease, then antibiotics play only a minor role, because antibiotics are not able to neutralize the toxins. Okay. But they can be used so that further toxins are not produced. And usually metronidazole is the drug of choice for treating tetanus. And the alternatives that you have, penicillin and doxycycline. And along with that, because your skeletal muscle will be out of control when you have a disease like tetanus, the symptomatic treatment is to intubate the patient, empirically, so that, that patient doesn't go into a respiratory arrest. Then give antispasmodic, because, like I said, a lot of spasm happening throughout your body, from your facial to your skeletal muscles, and you will be like possessed person. The person who is contracting tetani can look like a possessed person with all the contractions and spasms happening. And beta blockers to control the sympathetic activity. Okay, and like I said earlier, surgical debridement is the key when it comes to the wound. If you have a wound, if you have a suspected wound, if you have a suspected entry of wound, surgical debridement really helps. Now, coming to Clostridium difficile. Clostridium difficile, like I said, is a healthcare associated infection, and it is considered to be a negative, negative outcome that you can monitor in your hospital as part of your stewardship program. And the risk factors are prolonged hospital stay, because the spores are everywhere, and especially in the hospital, it is everywhere. And one thing I would like to say is that if you have a Clostridium difficile infection, hand washing is the key. Isolating the patient and cohorting the patients if there are a lot of patients with Clostridium is the key. And the one common mistake that I see is that people knowing that, like for our MDRO organisms, like our ESBL and CRO, whenever we go and see a patient, after touching the file and everything, we tend to use our hand rub to, clean from all the, if there are any organisms lying around. For Clostridium, because it is spore forming, the spores are not killed by your usual hand rub. Therefore, you need to use soap and water. If you're touching the file of a patient who had a Clostridium difficile infection, if you do not want to give it to another patient, always try not to contaminate yourself by unnecessarily touching anywhere near the patient. And before and after seeing the patient, hand rub will not help you for Clostridium difficile. You have to use soap and water. So coming to the risk factors, like I said, prolonged hospital stay, prolonged antimicrobial use, especially with cephalosporin, clindamycin, fluoroquinolones. And for clindamycin, even it is a black box warning that if you overuse of clindamycin can cause Clostridium difficile infection. And suppression of normal flora, having an advanced stage of more than 65, immunosuppression, cancer chemotherapy, having PPIs or H2 receptor antagonist, which reduces the acid, which causes the bacteria to grow more, can be one of the reasons, can be a risk factor for Clostridium difficile. Having malignancies and having surgeries are again the risk factors. Now, the pathogenesis is toxin mediated. You have toxin A and B. And toxin A is the enterotoxin, toxin B is the cytotoxin, and the diagnostic, how do you diagnose it? Based on the toxin production, you can send for toxin detection. What happens is that these toxins are, in the intestine, they grow and these bacteria will grow, and these toxins are released into the intestine, which causes disruption of the cytoskeleton of the cell, okay? Of the cytoskeleton is disrupted, which causes the cells to lose its shape. It doesn't adhere, the cells doesn't adhere as good as they used to, and the epithelial barrier is also broken, which causes a large volume, continuous loose diarrhea and pseudomembrane formation. Pseudomembrane formation is like flake-like, yellowish to, whitish and yellowish flakes that you see when you do a colonoscopy. You see a lot of patches throughout the colon. That itself tells you it's a pseudomembranous colitis. And it causes unformed stools. Because of this toxin production, unformed stool, multiple episodes of stool. This is how the clinical presentation of Clostridium difficile occurs. So in a patient who has been admitted in the hospital, whenever you have an unexplained, maybe fever with unformed stool, Clostridium difficile is something that you must look for. And it can cause hypertension, shock, ileus, and megacolon. With the hypertension, because of the large volume diarrhea that you'll be having, because of the BP drop, you'll have the hypertension going into the septic shock and a megacolon. Now, the antimicrobial therapy for Clostridium difficile is in itself a big, a lesson. And recently, there has been updation in the guidelines regarding the first-line agents and the role of other modalities. So, the three things that you can use that are commonly being said in the three agents that you can use are commonly being said in all the guidelines: vancomycin, that is oral vancomycin, fidaxomicin, metronidazole. Now, fidaxomicin is not yet available in India, but most of the guidelines, they have fidaxomicin as the first line in most of the cases now. The other thing is, for all the clinical pharmacists who are listening to me, oral vancomycin, okay? Oral vancomycin, because this is an intestinal infection, you need to have something that acts on the walls of the intestine, the pseudomembranous colitis. If you give it as an injection, it will not go into your intestine very well. Therefore, you have to give it topical. It is oral vancomycin. And in case if you are having a permanent case, a severe case where you have any of these complications that I've told you about, you have to give a combination of vancomycin plus metronidazole and a rectal instillation of vancomycin. Now, how do you give a rectal instillation of vancomycin? Either you can take your your capsule, vancomycin capsule, or the easiest thing that I have seen is to use your vancomycin IV vial, the drug that you get in the formulation for parenteral use. You can take it, you can mix it with 500 ml of water, NS, and have it rectally instilled at every 6 hourly, something that you can do if the patient is really bad. Okay, even if you don't have capsules for oral vancomycin, you can use the IV preparation orally. Okay, not IV, orally you can drink this one, or if a patient is comatose or unable to swallow, again through RT you can give the oral. These are the things that we have seen being used, and there have been studies regarding the comparison of vancomycin versus metronidazole for Clostridium difficile infection, and vancomycin is always superior to metronidazole. The studies, the RCTs have proven it. And when you have recurrent cases based on what you have used earlier, there are treatment options. Now, the other thing I would like all the clinical pharmacists listening to me to look, whenever you have a Clostridium difficile infection, is the dose. Okay, for mild to moderate, it is 125 mg, but when it comes to a permanent kind of a case, you give as high as 500 mg every 6 hourly. Okay, so every 6 hourly. So dose is something that you have to look for based on the mild, moderate, severe category. Your dose also changes. Okay, based on your recurrence, the dose can also change. And one of the recent things that have come as one of the first line agents itself is fecal microbiota transplant. So it's a very simple procedure. Anyone can, any hospital with a gastroenterologist and a colonoscope can actually do a FMT. It is not like your bone marrow transplant or the other complex system. You take the stool of a healthy person and you spray it with your scope, with your colonoscope or sigmoidoscope, wherever that this infection is there, because this normal bacteria will start growing there and it suppresses the growth of Clostridium. So it's a very easy procedure anyone can perform in a center with a good gastroenterologist. Now again, always IV vancomycin is not useful. IV vancomycin can be used orally, but not as IV. And there are some data regarding the use of oral teicoplanin, because we usually call teicoplanin like, the brother of vancomycin. There are some data, but we don't have solid evidence as to whether we can actually fully give teicoplanin. We still do not have that much data. Now, with that, we completed the anaerobes. Now coming to the atypical bacteria. So atypical bacteria, the first thing that should come to your mind is when you talk about pneumonia. So whenever you see a patient with a community-acquired pneumonia, you see the patient getting azithromycin, right? Or you see the patient who is admitted getting maybe ceftriaxone plus an azithromycin, or you put a patient on levofloxacin. The reason why you put these things than a beta-lactam, is because of this atypical bacteria. So there are three major atypical bacteria that we need to learn about. That is chlamydia, mycoplasma, and legionella. So why are these organisms called atypical? Because they are in their own way unique. Okay, and most of them, they do not have a defined cell wall. And you know that the gram stain that you do is based on the cell wall, whether it's gram positive or gram negative. Gram positive have a thick peptidoglycan layer. Gram negative has a thin peptidoglycan layer, and surrounding that is a thick lipid lipopolysaccharide layer, LPS layer. These bacteria, most of them don't have a cell wall. So when you don't have a cell wall, your gram stain doesn't work. So they do not turn up in your gram stain. Okay, and these are the three major ones that we are going to talk about. And I'm going to talk only on the pneumonia part of it, the atypical ones that you usually see. But there are other things as well, like rickettsia, coxiella, and all that actually comes under atypical. but you don't see that very often. So the three organisms that I'll be talking to you right now will be Mycoplasma, Chlamydia, and Legionella. Okay, and coming to the spectrum, like I told you, there are only very few drugs that will cover for your atypical bacteria, and that's why you see sometimes your patient having, even on piperacillin tazobactam, even on meropenem, a patient getting doxycycline or patient getting an azithromycin. That is not a duplication, that is not a spectrum duplication. It is not, if it's a patient with a severe community acquired pneumonia, they should get one of these drugs to cover for these organisms. Now, chlamydia is an obligate intracellular bacteria. So it is intracellular. Okay, that is the other thing. Mostly they live inside the cell. That's why, again, on gram stain, you don't see them. And chlamydia is usually, they resemble gram-negative bacteria. They do not have the peptidoglycan layer. Okay. And it was first recognized as a respiratory pathogen. And there are three major species of chlamydia. So, like I said, pneumonia is the first thing I want you to have in your mind. The second most one is a sexually transmitted disease, chlamydia trachomatis. So, chlamydia pneumonia, chlamydia trachomatis, and chlamydia psittaci. Okay, so these three are the ones that we need to know. And the atypical is usually known as the atypical that we are usually trying to cover is the chlamydia pneumonia. Now, it causes pneumonia, it causes bronchitis, and see, the other thing that I've learned is that atypical pneumonia is sometimes called as a walking pneumonia, because these are slow to progress, and usually if it's a pneumonia, you tend to get very sick, fall sick. But patients with atypical pneumonia, they're able to do things. It's a slowly progressing one. They just all of a sudden, they usually don't collapse when you compare it with like a streptococcus pneumonia. And therefore, the symptoms are also kind of very less. And the x-rays are also, the atypical pattern x-rays, it can be in the both lobes. It's like you have for streptococcus, you have a lobar pneumonia, you have a consolidation in one lobe or one of the branches. But atypical, it's more like it's there across. Okay, and PCR can be one of the way to identify this. And like I told you, I've shown you the spectrum. Macrolides, fluoroquinolones, and tetracyclines are the ones that you can use for chlamydia. When it comes to mycoplasma, again, they lack cell wall, and they have a unique cell membrane. Sorry, I've written it twice. And they're very small in size. They are very fastidious. They are very difficult to grow. And it contains both DNA and RNA. Okay. And the typical picture that you get when you actually have this on your culture plate is like fried eggs. It looks like, fried eggs on your agar. And it accounts for 20% of your community-acquired pneumonia. So now you know that 5 out of 1 can have this one, but it won't show in your gram stain. And it's very difficult for you to culture the bacteria. So again, if it is a pneumonia kind of picture, something that you need to have it in your mind, need for covering for the atypical when you're having this one. And the treatment again is the same when like the chlamydia. And the last one is the Legionella. So the reason why the Legionella got named is because of the Legionnaires disease. This happened, a large convention was happening in Philadelphia. And in this convention, what happened was that a lot of people fell sick. A lot of people fell sick because this Legionella bacteria is something that can, that can be in your AC vents, in your water. Water is something that, helps them grow. And if it is contaminated, the water tank, actually in this convention, the water tank that was, at that place where they were staying was contaminated with this bacteria. And the vents, these people, they just, had this bacteria coming in and causing this pneumonia. And a lot of people got sick. That's how it came, it's called the Legionnaires disease. And that is Legionella. And it is a gram-negative bacteria. and it needs a warm temperature. Okay. And like I said, exposure to contaminated water source, even your AC vents, if it is, and therefore, if there is an outbreak, that is something an environmental surveillance will look for. If many patients are having pneumonia, but it's not very common. But if there is, this is something that you should have in your mind. Like the other ones, the immunosuppression, male gender, age of more than 50, cigarette smoking, renal or liver disease, transplant, alcohol use are all risk factors to Legionella. And the infection is usually, like I said, from the AC events, the inhalation of aerosol bacteria, and it can, stay in your lung for, as an incubation period up to 2 weeks. And then there is a slow prodromal phase where you start to have small symptoms. And then comes your consolidating pneumonia or your pneumonia kind of symptoms the patient might be having. And one way of having a diagnosis is your urine antigen. And again, the treatment is your azithromycin, your fluoroquinolones, or your doxycycline. So with that, we come to the end of the atypical and the anaerobes. So again, the key takeaway for this session is that anaerobic bacteria, they always cause abscess. Most of them cause abscess. It's mostly there in your oral cavity, in your gut, in your genitourinary tract. The easiest way to remember: above diaphragm, below diaphragm. Below diaphragm is your bacteroids and the Clostridium and all the other ones. And above diaphragm is your Peptococcus, Peptostreptococcus, Prevotella. Even Prevotella is there down also. And metronidazole is something that you want to use when it comes to your gut. And maybe above your diaphragm, clindamycin may be one good choice if the resistance rates are not so bad. Okay, and beta-lactamase inhibitors. Beta-lactamase inhibitors are usually used because of the beta-lactamase enzyme that is produced by these anaerobic organisms. And one clinical pearl for antimicrobial stewardship practices is that when you have a patient with an intra-abdominal infection or a pneumonia, whatever it is, when you see a double redundant coverage is when you give a beta-lactamase inhibitor along with metronidazole, or a carbapenem, meropenem plus metronidazole. The reason the metronidazole is usually added for the anaerobic coverage, but these two drugs that I've told you about, beta-lactamase inhibitor, carbapenem, they already cover your anaerobes. Therefore, you do not have to give an extra metronidazole. This is one of the key antimicrobial stewardship pearls, antimicrobial stewardship activities, to step down patients with this duplication of coverage, duplication of spectrum to one agent, mostly the beta-lactam or the carbapenem. Okay, so that's about your anaerobic bacteria. And about the Clostridium, like I said, identification at the earliest is the key. Surgical debridement for all anaerobes with an abscess, because source control is your key. And oral vancomycin. Okay, oral vancomycin. Fidaxomicin is not yet available in India, and metronidazole may be added if it's a fulminant infection. When it comes to your atypical organism, Mycoplasma, Chlamydia, and Legionella, three of them that can cause pneumonia. The problem is it can actually, it is difficult to isolate this organism, but you'll always have to cover for this organism. So, and the drug of choices, doxycycline, your tetracyclines, your macrolides, and your fluoroquinolones. These are the three drugs that can cover for your atypical organisms. With that, thank you. If you have any questions, you can put it in the chat box.
Thank you, ma'am. You covered a lot of things in this short duration of time. We have a couple of questions. First one is, what is the role of metronidazole in treating Clostridium difficile infection?
Okay, so like I said, they have, a lot of randomized control trials have been there. which has assessed the superiority, whether metronidazole or vancomycin is superior. And they've always found out that vancomycin is superior to metronidazole. So, but still metronidazole is something that you can use. Metronidazole is usually an add-on agent rather than the only agent that you give. So for Clostridium, you don't give metronidazole alone. You usually start with vancomycin, oral vancomycin. And if it's a case that has some severity associated, there are various ways in which you can see if that patient is having severity. There are certain criteria like WBC is more than 15,000, creatinine, higher creatinine. All these things, based on that, you can assess the severity. And if you think that the patient is having severe Clostridium, you can add IV metronidazole. Now, again, why I said IV, because vancomycin, I said it's oral. But when it comes to metronidazole, oral metronidazole is not superior to IV. It has been found that oral metronidazole is less effective when it comes to IV. So metronidazole definitely has a big role, especially as an add-on agent, but not as a monotherapy.
Thank you. Last question. What are the rapid diagnostic tests for anaerobic gram-positive infections?
Anaerobic gram-positive?
Infection, rapid diagnostic tests for them.
Rapid diagnostic test, each organism, the thing is, you don't get too many scenarios where you are, forced to do that. Multiplex PCR is something that can easily actually help you detect. So all the multiplex PCR modality can be used to have, and specific things are there, but that will be a very long list of things. But multiplex is something that really helps you in identifying whether the patient has it or not.
I think that's it. The questions for now. Any more questions? Please feel free to email at fcpofficial@gmail.com. Yeah.
In the LinkedIn or in the FCP itself, once the slides are there, if there are still any questions, we can answer that.
I think that's it.
All right. I was scared whether I'll finish it on time. So anyway, I'm on time. So that's a good thing. Yeah. So shall I end the presentation?
Actually, ma'am, one more question.
Yeah.
If gram stain cannot detect the organism, how else can we detect them?
So like I said, PCR is always an answer. Like I said, when it comes to Legionella, urine antigen for Legionella is something that can be done. But the others, there are specific tests, but most of it's based on the clinical picture, whether you want to, whether you want to cover it as something, it's all based on your focus of infection, right? So for whenever you have a pneumonia, you don't look whether it's there or not. So my question is that if you have treated a lot of community acquired pneumonia, but how many of that has been proven to be an atypical? I have not seen many. I have not seen many at all. The only thing is, like I said, when it comes to a multiplex PCR, where you get to see a lot of organisms against a specific sample, that is something that can be done, but that is costly. Legionella, the urine antigen is also, I have not seen it used very commonly. But there are ways, like for chlamydia also, there are specific testing when it comes to STDs and all that. And but mostly it's based on the picture that you have a suspicion, you go for your diagnostic.
Thank you, ma'am. And participants, I would like to say again that feedback form will be made available in the comment box below the video thumbnail in the website. So you'll get your certificates after 7 days of submitting the feedback form. And if you have any other doubts, please feel free to contact us at fcpaofficial@gmail.com. And all the videos till now will be made available in the website. I think that's it. Thank you, ma'am.
All right. So bye, everyone.
Bye bye.